Nurses really are the professionals who educate how to take these medicines, why we use multimodal therapies, why it isn't medicine alone, helping patients to understand that pain is a biopsychosocial spiritual phenomenon, and the pills are just going to hit one little aspect of that entire phenomenon.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Conferences Clinical Specialist at ONS. Today, we're talking with Judy Paice, Director of Cancer Pain Program at Northwestern University Feinberg School of Medicine in Chicago, Illinois, about pain management nursing strategies in cancer care. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining us today, Judy.
Thank you for inviting me, Lenise. This is so exciting.
Always exciting to talk about cancer-related pain and ways that we can manage it. Let's start with some of the basics about cancer-related pain. We know that pain can occur at any point throughout the cancer continuum. Can you explain some of the causes of cancer-related pain and when patients are most likely to experience these kinds of pain?
So that is such an important question, Lenise, and it is evolving. So for people like me who have been in this world working in oncology nursing for many decades, the previous primary causes of pain were the tumor. Now, with much better local control of the disease, we see that more and more of our patients are experiencing pain related to the treatment. So let me explain that a little bit more. Yes, many people present with pain. I think of the myeloma patient who's got quite a few lytic lesions. A really classic presentation is some back pain, and they go to their PCP and they get some PT or physical therapy, and it doesn't get better, and more investigation is conducted, MRIs, lab values, and they are found to have myeloma. So they present with severe pain, and I typically will see these folks early in the course of their illness, will ramp up the pain medicines, and then after they get a few doses of their standard oncologic treatment, we see the intensity decline. And in fact, we can wean people off of the pain medicines. So the causes of the pain can still be the cancer, but we see less intensity, shorter durations with more effective treatment. Now, I mentioned treatment is more commonly a cause of pain. And part of that is because people now, with our very effective therapies, are living longer and longer. In many cases, cancer is more like a chronic illness. So we see the typical kinds of surgically related pain, the phantom sensations after sarcoma, post-mastectomy syndrome, post-thoracotomy or post-VAT syndromes. And those are even occurring less and less frequently. We do see some chronic pain syndromes with chemotherapy and now with immunotherapy. For example, chemotherapy-induced peripheral neuropathies. And with the amount of steroids that we often have to give, we see that many patients develop bony complications like compression fractures or avascular necrosis. Radiotherapy is amazing in the way it has evolved over time. With more conformal treatment, less of the healthy tissue is exposed, and we see less of the fistula formation and bony complications. So that's another area that is declining in terms of prevalence of chronic pain syndromes. It can still occur, but it is not as common as we used to see or as devastating. And now, with the advent of stem cell transplant and CAR T type therapies. Certainly with stem cell transplant, we see graft versus host disease. And in terms of long-term complications of CAR T, I think that story is evolving. And then for our patients with breast or prostate cancer, we certainly see long-term complications associated with hormonal therapies or aromatase inhibitors. And those can include bony complications. For our male patients with prostate, we may see gynecomastia. So that's just a quick introduction to the wide array of pain syndromes that can be seen. Now, why is this important? Because who do our patients talk to about their symptoms, particularly pain? They talk to their oncology nurse. So we need to be aware of the possibilities. I mean, the good news is a recent study was published that demonstrated that the overall prevalence of cancer-related pain is actually decreasing. So that's a really exciting response to all of our treatments.
That is exciting. And I will echo you. For the time that I've been in practice, the types of pain that I've seen changing over time and the responses that we've been able to get with the medications and the types of therapy that we're giving has definitely gotten better. Moving on a little bit more about the nurse's role in pain management, can you talk a little bit about what they might do in relation to assessing pain or managing pain in cancer care?
That's another really superb question. And I'm so glad ONS is sponsoring this podcast because I don't think we emphasize the role of the nurse sufficiently. I don't think the general public understands, nor do other professionals understand the key role of the nurse. As I mentioned, who do patients speak to about their pain? They're often afraid to tell their oncologist, and studies have backed this up. The patient is worried that if they admit to more symptoms, they won't be able to enroll in that clinical trial. So they talk to us, the nurse. And part of our role is to encourage that dialogue and assess the pain fully. And that's a much more involved kind of exercise than it was in the past, because so many hospitals, unfortunately, have emphasized intensity, but it's so much more than that. Certainly, we're very concerned. It's this mild pain, moderate pain, severe pain, because we know the more severe the pain is, the more it affects behavior, function, quality of life. And we certainly need our patients to move and to meet their goals as much as they can. It also includes the quality of the pain, multiple locations of pain. Our patients are on average a bit older, so they're going to have non-cancer causes to their pain, like arthritis, for example. So we don't want to miss that either. And we want to ask about what they've tried in the past, so we don't reinvent the wheel. And we want to take, besides a good history of their pain, we also want to take a good history of their past use of substances. Now, we can talk more about that later, but we want to do a bit of a risk profile. I know that the media has focused on the horrible and sad stories of some adolescent being exposed to an opioid after having their wisdom teeth removed, for example, and then, unfortunately, then having episodes of substance use disorder. It's more in depth than that, as most oncology nurses already know, that there are risk factors for the development of substance use disorder. And the earlier we ask about that, the earlier we can help to mitigate that potential. We also need to take a good exam, and certainly our background in our settings of care are going to dictate what that exam may include. But even something as practical as, something like foot drop. I'm seeing patients all the time. Just as they're walking to the exam room, are they dragging that foot? Would they benefit from either an orthotic or a referral to physical therapy? Because if they're dragging that foot, they're going to fall. We want to prevent those complications. So in addition to that, nurses really are the professionals who educate how to take these medicines, why we use multimodal therapies, why it isn't medicine alone, helping patients to understand that pain is a biopsychosocial spiritual phenomenon And the pills are just going to hit one little aspect of that entire phenomenon. And so helping people understand that when we recommend physical therapy, it's really to help them function better. Or when we talk about getting some mental health counseling, it's for their benefit so that they can sort of pull together all of those inner resources that they already have, but maybe have gotten drowned out by all of the work they're doing to manage their cancer. And nurses are the people who prevent and treat the adverse effects of our pain therapies. They call me the pain and the poop nurse in our clinic because I am constantly assessing the individual's bowels and how often are they having a bowel movement? What's the consistency? What are they currently using? Because if we don't do that, your patient is going to end up in the emergency department being disimpacted. And that is never a good thing. I will also suggest that nurses play an important role in advocacy. It's a tough time right now getting pain medicines and getting access to all of the pain care that's really needed. Medicines, non-medicines, non-pharmacologic therapies, getting that paid for, doing the prior authorizations. Nurses can advocate for individual patients, and then we can advocate nationally with our national leaders in ONS and with our legislators to make sure they're aware that it's really a tough time and that our pendulum is actually going back, that it's more difficult to treat pain adequately. I know that was a lot, Lenise. Hopefully that was helpful to you.
That was very helpful. And the point about the advocacy thing, I think that the difficult thing is if we're having trouble getting pain medications and treating pain for our patients, then they might be starting to look for sources that could actually treat their pain. So I think it behooves us to advocate as much as we can to make sure that we can get them the treatment that they need.
Agree, 100%.
Within what you just mentioned, you talked about both pharmacologic and non-pharmacologic interventions. Can you talk more about that?
The pharmacologic therapies, I like to kind of divide up into three broad groups. I just keep it simple, right? And when I'm interviewing a patient, I'm really kind of checking off the box about those three different groups. So the first are the non-opioids, and that would include acetaminophen and the non-steroidal anti-inflammatory drugs. So with acetaminophen, we have to be careful. This is another important role for nurses when we do medication reconciliation. How much are they taking from the medicines we're prescribing, and how much are they taking from the over-the-counter medicines? And I'm constantly finding levels of acetaminophen that are higher than the recommended 2,000 to 3,000 milligrams per day. People forget to report the over-the-counter meds. They think they're not important. They weren't prescribed. So this is really crucial. And it's not just acetaminophen. And by the way, that 2,000 to 3,000 milligrams, over that dose, we worry about liver toxicity. Now, the non-steroidal anti-inflammatory drugs are analgesic, antipyretic, so is acetaminophen. But what's different is the NSAIDs, the non-steroidal anti-inflammatory drugs, are also anti-inflammatory. So they're really helpful for bony type pain, arthritic kinds of pain. Yet they've got some adverse effects that are really important in the oncology population. So, for example, non-steroidal anti-inflammatory drugs can cause renal dysfunction and can be especially damaging in someone who already has a compromised renal system. They can cause GI bleeds. So we need to be cautious about that. And what's often overlooked is the increased risk of cardiovascular adverse effects, particularly stroke and MI. And this is true in people who already have risk factors. So our 85-year-old patient who's had a previous MI, who's got hyperlipidemia, hypertension, they're really at great risk. So is the benefit of the NSAID stronger than the potential risk? We need to really discuss that and consider that given the patient's goals of care. So that's the first category of drugs. The second category of drugs are the opioids, and these work on a wide variety of pain, and they are so stigmatized right now. And what I'm seeing around the country as I talk to colleagues and in my own institution, so many efforts are being directed to use the least amount of opioid that all of a sudden everybody is getting 3 other medications instead of an opioid. We can talk more about that later if you'd like, but it's a real concern that I have. And then the third category of drugs are sort of a catch-all. We call them the adjuvant analgesics. These would be the gabapentinoids, like gabapentin or pregabalin. They would include the SNRI agents like duloxetine or venlafaxine. These agents all tend to work very nicely for nerve pain. And duloxetine in particular is also labeled by the FDA for musculoskeletal pain and nerve pain. This may also include local anesthetics, corticosteroids, or other agents that may be available in different settings. So that's a quick overview of the pharmacologic. And then the non-pharmacologic, which is equally important. And I see these as partners in relief, not as one versus the other. But we may have physical measures like PT and OT and orthotics, heat and cold. We may have more emotional or psychological kinds of therapies, cognitive behavioral techniques. We may have integrative measures, mindfulness, guided imagery, yoga, Tai Chi, and some of these kind of transcend multiple categories. And then we also have invasive measures like nerve blocks, radiofrequency lesions. And I'm constantly referring patients to my anesthesia pain colleagues to do these kinds of procedures for patients. And in different institutions, you may be calling anesthesia or you may be calling interventional radiology. So you kind of need to know who the resources are in your setting. So again, pain is a biopsychosocial spiritual phenomenon. I've kind of addressed at least 3 of those sections. Don't forget the spiritual, and that doesn't necessarily mean religious. It's really questions about our existential meaning in this world. So who's the best person to address this for the patient sitting in front of you? Someone with a spiritual community in their life may be best served by talking with their spiritual leaders, their pastor, their rabbi. For the person who doesn't necessarily rely upon a spiritual community, it may be other kinds of colleagues or support persons. It may actually be mental health counseling to listen to their concerns. And for many, it's palliative care to help address all of those aspects.
That's a lot. And I think that's so important. And it's one of the things that's so important about being a nurse is that you're really addressing the whole patient. And so if we can look at pain from that perspective as well, then I think we're a step further ahead in managing their pain.
Yeah, Lenise, we are definitely on the same page. I think nurses tend to see the entire person sitting in front of us. It's one of our skills. It's our secret sauce, as they say.
Exactly. Let's get a little bit more specific on how we treat different types of pain. Can you describe management for specific types and maybe highlight some of the similarities and differences in those strategies?
Yeah, and thanks, Lenise. This is a model that was actually shared with me a while back, and it really resonates. So when I'm teaching other nurses, the medical students, others, even patients, I like to think about the quality of the pain. And that helps me to first think about the pharmacologic therapies and then more broadly about the non-pharm. So here's an example. Nociceptive pain, described by patients as aching, throbbing. A very classic example in oncology would be bone mets, for example. They tend to be pretty localized pain sites. The patient can typically identify where that pain is located and what seems to exacerbate that pain or mitigate the pain. So for nociceptive pain, I think of the non-opioids if they're not contraindicated. And if the pain is more moderate to severe, the opioids. For neuropathic pain, honestly, this is described as tingling, burning, electrical shooting. You often get a dermatomal distribution. So think of that patient with a compression fracture or with a vertebral body malignancy. There's instability in that vertebral body. So there's compression against the nerve root. The patient is actually going to have radiating pain. The patient may call that radiculopathy or sciatic. Radiculopathy is usually the medical word. So many of our older patients will say, I have sciatica. So, and that follows a dermatomal distribution. Another example might be the person with a shingles outbreak, for example. Often I see that on the chest or in the facial area, in the chest or the thoracic region. And again, we'll follow a dermatomal distribution. That's one of the hallmarks of neuropathic pain. For neuropathic pain or nerve pain, typically the non-opioids are less effective, if effective at all. The adjuvant analgesics are really where we focus on for neuropathic kinds of pain. And if the pain is more moderate to severe, this may be where we might use opioids. Sometimes I use opioids as a bridge because most of those adjuvant analgesics take about a week or so to take effect. So if somebody is in the hospital with a severe outbreak of shingles, for example, and we start them on a gabapentinoid, they're going to need something for that week while we're waiting for the gabapentinoid to be titrated upwards and to provide adequate relief. And then we can wean down the opioid. I do find that there's a lot of misperception that opioids don't work for neuropathic pain. And clearly, we're not going to use opioids for someone with diabetic peripheral neuropathy or even now for chemotherapy-induced peripheral neuropathy. But they do work for nerve pain. So we have to think about the risks and the benefits. The studies have demonstrated that when you use opioids for neuropathic pain, you tend to need higher doses, which means more adverse effects. So again, it's a balancing act. And then visceral pain is our third kind of pain. And it is so unique. I know in many of the textbooks, it's kind of considered a subtype of nociceptive pain, but I think it's so unique. It deserves its own category. Think about the worst case of traveler's diarrhea you've ever had. It's squeezing, it's cramping, it's diffuse. You can't really point to an exact site like you can with the other two pain syndromes. And here's what's really different. You can have referred pain. So of course, the classic example is an MI, right? People will experience it in the left jaw, the left shoulder, down the left arm. Think about our patients in oncology with liver disease, liver mets, or primary liver tumors. They may have pain in the right upper quadrant, but they'll also experience pain in the right shoulder or upper back. So we certainly use opioids for visceral pain, and I'll try adjuvant analgesics for some of those visceral pain syndromes. There's not a lot of great data, and that's where we need a lot of research in all of these areas. Honestly, I find that corticosteroids are brilliant for that right upper quadrant, abdominal pain with right shoulder type pain. Really, really helpful. So I've just kind of given you a quick paradigm that I hope people find helpful. Always, always treat the underlying cause, of course. And I know you all know that. So if this is C. diff, we treat the C. diff. If this is a colitis from immunotherapy, then we treat the colitis and maybe give them a short drug holiday. If it's constipation, we treat the constipation. But in terms of the broad categories of pain, those are just some helpful paradigms. At least I find it helpful in my clinical practice.
That was very helpful. I think one of the other ones that we think about is that even if we've managed to create a regimen that is managing a person's pain very well, we know that sometimes they have an increase in pain or breakthrough pain. What are some treatments that are available for breakthrough pain?
Yeah, and this is another area that's evolving, Lenise. Honestly, for breakthrough, we try to, again, treat the underlying cause. If this is an unstable vertebral body, is a kyphoplasty or a vertebroplasty a possibility for this patient? If there's compression of nerve roots, might an epidural steroid injection or some other interventional procedure help so that when the patient stands, and that's often when we see the breakthrough pain occurring or moves position, maybe we can provide some relief that's more directed to the site of pain or source. Same thing with radiotherapy for bony mets, for example. But in the meantime, when we're trying to get this under control while we are waiting to address the underlying cause, really our armamentarium is short-acting opioids. For a while, there were transmucosal immediate release fentanyl products. And there was a lot in the literature about these products. There was the fentanyl product on a stick that would be placed against the inner aspect of the mouth. There was film, there were sprays. Well, just within the last couple of months, these things have been removed from the market. Quite frankly, they were extremely expensive. It was really difficult to get insurance approval. And for some of the products, their onset wasn't that much more rapid than taking an immediate release opioid. So again, here's an area where nurses play a really essential role. When you advise someone to take an immediate release morphine or oxycodone or hydromorphone, for most people, they begin to feel something in 20 to 30 minutes, but the peak effect is about 1 hour. So helping people understand how to utilize that pharmacokinetic profile is really within the nurse's purview. So if it's painful for my patient to lay on the table to get their radiotherapy, then an hour before they're going to be on that table is when they need to take that short-acting opioid, not right before they climb onto the table. Or for some of my patients, it's the twisting motion that's required to get into their car and be driven to their appointments and bouncing over Chicago potholes. They need to take that medication preemptively. And without that kind of education, that's not really in the mindset for most of our patients. So yeah, it's really important that we help use the medicines that we have to provide optimal control of these quick pain episodes that can occur that has been often called breakthrough pain.
Judy, you've given us a lot of information so far. Can you apply some of this in a way, maybe like a case study of a patient with cancer-related pain and the management strategies that have been used for those?
You bet. Yeah, Lenise. I always find case studies really helpful. It really helps to solidify, for me at least, how I might use these different treatments. So a classic example might be a person that I see with head and neck cancer who may or may not present with a lot of pain. And they come to us and they're going to undergo a really painful therapy. And that is chemosensitizing radiation that usually administered over 5 to 6 weeks, depending upon the particular tumor. And for some patients, this can be so severe that they have difficulty swallowing. They can barely swallow their own saliva. And although we really try to do everything we can to prevent the placement of an enteral feeding tube, there are just some people where that is precisely what occurs. So I will typically start these individuals on a gabapentinoid early, immediately. We know that the nadir for the pain, at least the onset for the pain, is generally around week 2. Obviously, it varies from patient to patient, so we need to do ongoing assessment. But even before that, starting with week 1, I'll start with low doses of gabapentin or pregabalin. I may actually use the capsules, or I might use liquid, just because I know at some point many people are going to need a liquid. And we will ramp up the dose slowly over time, because this does tend to be a lot of a neuropathic quality to the pain. And then for many, we end up slowly introducing and titrating upward an opioid. And again, I try to be preemptive. Many people are going to need a liquid. So what are the liquids that are available to us? The high concentration liquids would be morphine or oxycodone. Those are available in a 20 milligram per milliliter concentration. And therefore, the patient can really take a very small dose of the medication. And of course, we're also going to use topical solutions. I know there's a lot of controversy about the use of the different products and the efficacy of these different products. So we may introduce those as well. And then once we get people through that 5 to 6 weeks, we have to help them understand that the treatment is still effective for at least 2 more weeks. So many radiation departments, people will bang that gong and they think, okay, why am I not better tomorrow? Again, it's a lot of education. And then we slowly, gradually wean down. I generally start by weaning down the opioid and weaning down the gabapentin after that, or pregabalin. So it is a lot of education, a lot of check-ins to continually reassess. But that's just one example. And I gave you the other example about our myeloma patients and how they also start out with pretty significant doses of an opioid at times, and then we wean down over time. I would also caution everybody regarding the use of the gabapentinoids. We start slow and work it up because some people do get a little dizzy. You need to be really cautious about their renal clearance. So I always check the creatinine clearance. If it's less than 60, typically have to reduce the dose of the gabapentinoid. It isn't harming the kidneys, but they aren't able to excrete the drug adequately, and you may see toxicity. So that's just one example. And I hope that case gave you some ideas, Lenise, about multimodal care and how it changes over time.
Yeah, that was a very excellent example. And I know we often will use a head and neck patient as an example of complex care and how we can weave their care and how it changes over time over the course of their treatment. So I think that was an excellent one. And that myeloma one that you used at the beginning was also a very excellent example. You talked earlier about how nurses can be advocates for their patients. Can you expand a little bit more on how nurses and other healthcare professionals can be those advocates and how it might change throughout the cancer trajectory?
And I alluded to some of the challenges that we're facing now. You know, the face of advocacy can vary quite a bit. It can be for our individual patients. So we all should be aware of those people who are at risk for underassessment and undertreatment of pain. So as we're seeing individuals, kind of keep an eye out for those who are at risk. And they are the very young and the very old. There are misperceptions that the nervous system isn't fully developed in children or that they're more at risk for addiction. So people tend to undertreat kids. And the older adults, and our older adults kind of contribute to that a little bit because they're reluctant to complain. They kind of think, well, this is just part of getting older. We tend to underassess and undertreat in those folks. Certainly our patients where English is, or I should say the language of the healthcare provider is not concordant with the patient. I wish I were smarter and I spoke other languages, but I don't. And so I know when I'm using a translator or an interpreter, I know I'm missing key points. And so as a result, I need to be really cautious that I'm not undertreating in those individuals. And then people with poor resources, poor insurance coverage, for example, we know we're going to have lots of challenges getting them the treatments that they need. So that's on an individual basis. And I also should add people with substance use disorder. There is a lot of stigma and belief that, we can't use controlled substances in those individuals. And in many cases, particularly those with advanced disease, it's absolutely imperative. It is concordant with evidence-based care and all of the clinical practice guidelines that they need pain treatment. It just takes a different kind of approach that you may take with people who have less risk. So those are the individual kinds of advocacy efforts. We also need to advocate globally. And I kind of mentioned this before. we are having a terrible time getting pain medicines for patients. Most of our medicines are generics. I know we tend to get sloppy and use a lot of trade names, but rarely are the opioids that we're prescribing really trade. The manufacturers don't have a lot of incentive. If something goes wrong with the supply chain or their manufacturing processes, you notice we never run out of Viagra, but we have so many shortages right now. In my neck of the woods, it's hydromorphone. A couple months ago, it was fentanyl patches. So we're seeing this all around the country as I talk with nurses from every region of our country. We also see insurance companies and these pharmacy benefit managers, PBMs, they call them, putting up so many roadblocks. And I know ONS and ASCO and other groups are working hard to try to counteract these efforts, primarily associated with chemotherapies and anti-cancer treatments. But the opioids are also a huge problem in terms of trying to get approval. We typically can get approval, but by that time, we're already, facing delays. And I've had many circumstances where people are going through withdrawal because of the challenges and the delays associated with getting approvals. And then our retail pharmacies are suffering terribly right now for a variety of reasons that are beyond the scope of our discussion today. But try to call a retail pharmacy and see if they even have a supply of the medicines. You can't get through. They're being rationed by their higher ups. And so they typically are carrying low doses or very little opioid. And there are some chains that are even more reluctant. There are chains that are implementing policies that vary from state to state. I practiced in Chicago. Just a couple months ago, I had a patient in Indiana where on a Friday afternoon at 4:00, he needed a prior authorization for his medicine that he had been getting for several months. And by the way, this gentleman had a terminal diagnosis, but was not ready to enroll in hospice because he was in a phase 1 clinical trial. This pharmacy chain in our neighboring state, when I said, I'm not going to be able to get a prior authorization late on a Friday afternoon. This is an inexpensive drug. Can we use good RX coupons? And the patient is willing to pay the $20 out of pocket. The pharmacist stated, we no longer accept cash payment for patients who are receiving opioids. And I had another experience in the same state with a different patient. So it wasn't something selective to that patient. So that is just abominable, unethical, and it is putting our cancer patients in severe risk. Those are the issues getting our pain medicines, but even getting physical therapy to be paid for, getting our non-pharmacologic therapies paid for has been really challenging. So we as nurses need to advocate. Yes, there is a horrible, horrible opioid misuse epidemic or substance use disorder epidemic, and it has devastated many families, many people around our country. We can't go back to those early days of cancer pain management where people could not get their opioids, where we only treated people who were actively dying. So please let your legislators know about these challenges. So that's the advocacy that we as individuals can do and that ONS can do as well. I know I went on a little bit of a soapbox, but it is really dangerous and the situation is really fragile right now.
Judy, those stories are heartbreaking, and I'm sure every single one of our listeners has a similar one that they have faced during their career. We just want to bring the best care possible for our patients. You've talked a lot about substance use disorder and have woven it in, but let's focus on it just a little bit because we know that you just mentioned the problem that we have in relation to providing adequate pain management because of substance use disorders. But you also talked about how you can treat a patient with substance use disorder with opioids. We've already had a podcast that's covered this, but can you briefly describe some best practices related to this?
Yes, Lenise, I think, none of us in oncology or very few of us have been trained in managing substance use disorder. And yet many of us are, in circumstances where we are seeing a good number of people. And, as I mentioned, it's a disease. people feel stigmatized. So the first thing we need to do is include it in our history taking in a very non-judgmental, curious way. There are tools that can be used. I'm not a fan of the opioid risk assessment tools that are available. And my rationale is I prefer to ask the questions and I can then drill down a little bit. So when I'm asking, have you ever used heroin? And someone says, oh yeah, I used it in college. How difficult was it to stop using? Oh, so easy. I only just experimented a little bit and it was stupid. And, versus the person who says, well, I'm still using it today and I've tried rehab several times. So we know that there may be an incentive for that person to think about rehab again. It helps me to understand the whole person a little bit more specifically. So a good, strong risk assessment. And one of my colleagues pointed out that some of those tools actually are pretty stigmatizing and biased. For example, one of them asks, have you ever been incarcerated? Well, that's clearly got a bias against our patients of color. And it really doesn't have necessarily anything to do with treating substance use disorder. So a good assessment, collaborating with other members of the team is really important. And then I set expectations. Again, this is where nurses are key. It is so important that you use these medicines for pain. Yes, they're going to make you feel a little bit less anxious, a little warm and fuzzy, and maybe even help you fall asleep at night, but you cannot use them for that purpose. You can only use these medicines for pain control. We have other medicines to help you if you're feeling anxious or if you're having trouble sleeping at night. And if you use your opioids for those purposes, you are going to get into trouble. So setting expectations, and also that the goal, as much as we wish it could be no pain 24/7, for most people, there are going to still be times when they experience some pain. And then, of course, I do urine toxicology randomly on all of my patients. And that's because if I just did it for people where I thought there was an issue, I'd be demonstrating my implicit bias. I also check the prescription drug monitoring program. Now, because I do follow a more complex population of people, I check it all the time. Other recommendations for most people may be, check it every 3 months or so. I check mine all the time. And honestly, it's not just something to be used punitively, which is unfortunately where I've seen some of my colleagues go. I like to use it. It helps me to understand when will insurance pay again for this medicine. I once had a gentleman come from Arizona. His daughters were bringing him up. He was an elderly gentleman and they needed to take care of him now. He wasn't safe to be on his own. He used his last pill the night before our encounter and they didn't save the bottle. They didn't know the name of the medicine he was taking. My prescription drug monitoring program in Illinois can access about 20 other states. So I was able to access Arizona and see he was getting oxycodone, long acting, and the dose. So that was really, really helpful. I think overall, you've already had a really important podcast on this topic. I think honest, non-stigmatizing, non-judgmental communication and conversations are so crucial. And then just to be aware of our own implicit biases.
That leads me directly into my next question. How can a health professional identify their own unconscious or implicit biases about pain management?
Yeah, Lenise, have you ever been directed to the Harvard Implicit Association test? If not, I encourage everybody to try it. It's really informative. It's free. You do have to consent that your data might be used, but it's not identified at all. But it has, so just Google a Harvard implicit bias or a Harvard Implicit Association test. You'll get directed right to the site. You can look at your own biases about age, religion, race, body size. It is amazing. And it really, I think, very accurate. It's really informative. So then what do you do with that? Well, self-awareness is really key. And then talk to experienced colleagues, talk with others who you value and trust, and be honest and see how they've addressed their own biases over time.
Thank you. And thank you for that plug for the Harvard test. I think I might be headed there this afternoon. This has been a great conversation. Thank you so much for everything. I just have a couple of more questions for you that we ask all of our podcast people. What are some common misconceptions about pain management?
Well, and be careful, Lenise, because I could talk all day about pain. So you stop me when it's time. So I think some of the biases I've heard is that, it's a weakness to experience pain. I've heard professionals say nobody ever died from pain, when frankly, I think people who have severe pain aren't able to walk. They're more likely to get DVTs. They're not able to inspire deeply. I mean, we all know this. Pain can be devastating physically and to the quality of life of that person. And then also to the family members who are remembering that loved one for the rest of their lives. So I think that's a really harmful misperception. And then the other is that everybody on opioids becomes addicted. And I know it is so hard. Again, it is a devastating epidemic that we face right now. And yet cancer pain is a horrible phenomenon that demands ethical treatment. And we are smart people. We can hold both of those truths at the same time. Those are some of the big misconceptions that I see about cancer pain and cancer pain management.
Definitely the ones that I think of most often. What's something about this topic that's not often discussed, but you wish people knew more about?
Yeah, I mean, I've already talked about the fact that this is a really challenging time, and this is not to be a Debbie Downer, but just I have a sense that most oncology nurses know this, and to acknowledge it helps people just to validate the challenges that we are all facing right now. And I hope to provide some solutions as well. I also want to make nurses aware that our trainees, nursing trainees, medical student trainees, interns, residents, fellows, they're no longer getting treatment of pain in their underlying curricula. They're getting opioid stewardship, which means don't give opioids. And I often have fellows shadowing me in clinic, and they'll often admit, it's how not to use opioids has replaced the curricula related to pain. So those are some things we need to work on, and really don't assume that those physician colleagues or young nurses coming into the profession really understand this. You may be starting from ground zero with them.
Wow. To that next point is, what additional training or education can oncology nurses access to stay current on this topic? Because if they're the ones that are shepherding it, then they need to stay current.
So, Lenise, I think the ONS website has lots of resources, and all of the ONS congresses and other educational offerings are directed to oncology nurses and really address many of these issues. I would also say that the ELNEC, the End of Life Nursing Education Consortium, which really arose from oncology nurses, and although we've expanded to include others, we've got some great training programs. And quite honestly, there is a grant-funded oncology APRN course that's offered annually. And a lot of that content is specifically focused on pain management, because we know it's the advanced practice nurses who are primarily prescribing to relieve symptoms, particularly pain. So there are many CE kinds of programs available, and I would just commend people to ONS, to ELNEC, the End of Life Nursing Education Consortium, and many others.
What about some resources for patients and providers who want to learn more?
Yes. So again, ONS is a great resource. There is a resource that I find underutilized and is really amazing, and it is from the National Cancer Institute, and it is called PDQ, and there is one that's specifically on cancer pain. And what I like about all of these PDQ offerings, they have them specific to disease entities, they have them to other symptoms, to transitions in care, all sorts of other phenomena that nurses find really helpful. Not only is there a professional version, there is a patient version. So you can direct your patients to these PDQ resources through the National Cancer Institute. And then, of course, ONS, ASCO, the American Society of Clinical Oncology, has patient-directed resources, the American Cancer Society, and there are many specific groups that are focused on disease sites, like the Leukemia and Lymphoma Society, and many others have lots of great teaching materials.
Thank you so much for spending this time with me. Judy, this has been amazing talking to you. It's been very eye-opening for me. Do you have any final comments for us?
Lenise, I just want to thank you and thank ONS for, throughout my career, starting me out as a brand new oncology nurse on my very first job, and always being attentive to symptom management and providing educational opportunities so that we can do the best job feasibly.
Thank you so much. And I hope you have a great rest of your day.
You too. Thanks, everybody, for listening.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.